Welcome, everybody, to SADS Live, episode 168. My name is Andrew Landstrom, and I'm a pediatric cardiologist and genetic scientist from Duke University. It's my pleasure to be hosting SADS Live today, subbing in for the excellent Dr. Mike Ackerman. And I'm excited to take your SADS-related questions today over the next few minutes. A few announcements before we dive into the questions. Looking ahead, you all are in for a treat. There's going to be additional SADS Live episodes coming in the next few weeks on a different day, starting on Tuesdays, with our next Tuesday SADS Live episode being on October 28th at 12:20 Eastern Standard Time. It is also October is Sudden Cardiac Arrest Awareness Month. And so please, check out SADS. We're going to post a link to some wonderful ways that you might be able to get involved through the SADS organization for Sudden Cardiac Arrest Awareness Month and pitch in. You all are part of a very important community, and SADS has great ways to connect with that community. And so with that, let's dive in and see what we have in terms of questions from you all. So we have a question from, I might mispronounce the last name, but Banasakowicz, Miss Banasakowicz, during an exercise test, what QTC values would suggest long QT if the baseline QTC is around 460 or 470 for women? And so this is a great question, and we'll sort of talk broadly about the role of an exercise stress test. So there are many different types of exercise stress tests that your SADS specialist might ask you to do. One of the more common ones is a treadmill. So if they invite you to take a stress test, go ahead and wear good running shoes that day. We have kids in our clinic who show up in all kinds of things. So wear good running shoes. And you'll start with a slow sort of walk and build up speed and build up incline. And the idea with that stress test is to see how your heart does with exercise as you run faster and go up this incline. There are certain things the SADS expert will look for during that test. So the first one, kind of what was brought up earlier, is what's the QT interval at baseline? So what is it when you're just sitting in a chair at baseline? And that can be very helpful because that's sort of your resting QTC. Sometimes with some stress tests, as your heart rate goes up, the QTC does something quite different. In most individuals, as the heart rate goes up, the QT shortens and the QTC stays roughly the same. That's the corrected QT interval for heart rate. And that's important because as your heart goes faster, you want that QT to shorten so that your heart can beat again at a faster rate than maybe when you're just sitting down. However, in some individuals with long QT, that can actually be backwards, and the QT interval can prolong. The QTC can actually prolong, and that might be a sign of certain types of long QT. The other thing that the QT interval can do is prolong after the stress test is already done. So after you're sitting in a chair and you've run as hard as you can, and they say, okay, you're done, and you're sitting, the QT interval should go back to normal. And if it was short when you were running, it should prolong and back to your normal baseline QT interval. There are some patients with QT prolonging disease where that actually prolongs abnormally even more than we would expect during that recovery phase. And so these types of observations can be clues for perhaps there is an underlying long QT syndrome there, and perhaps genetic testing might be in order. There are other reasons to get a treadmill stress test or an exercise stress test. For example, if you're having symptoms during exercise, the idea being that with all the rhythm monitoring that's on during that test, how do you feel when you're exercising? And if those symptoms come out, what is your heart doing from a rhythm perspective with those symptoms? That can be very, very helpful too. So lots of reasons to get a stress test, lots of reasons why your SADS expert might want you to do so, and some of the things that you might be able to discern from that stress test. I hope that answers your question. A question from Instagram. During breathing-related heart rate variability, does my QT interval need some time to adapt to the changes in heart rate? Could this explain why sometimes I sometimes briefly have a QTC of 485 to 490 milliseconds? So heart rate variability is a big time predictor of what your QT interval is. So for example, like we just talked about, if your heart rate slows down, the QT interval, the actual measurement of the QT interval on the ECG, which measures how long it takes for your heart to electrically reset, that prolongs, that takes more time. And normally, as you exercise, for example, that shortens up. Uh, Individuals who have long QT, that is prolonged, but it's prolonged across lots of different heart rates. And so when we talk about QT interval, oftentimes we talk about the QTC, which is what the person from Instagram is asking here. And that little c in QTC is corrected, meaning that QT interval is corrected for heart rate. So if the QTC is prolonged, that means across lots of different heart rates, that QTC interval is prolonged. And for example, 485 to 490 would be a little bit prolonged, a little bit higher than we'd expect in most normal individuals. There are many reasons for that, and why that number may change from day to day. And it can be because of the salts in the blood. It can be because of dehydration. It can be because of medications, which we might take that can prolong the QT interval as well. For example, in biological women, biological females, estrogen, circulating estrogen during the childbearing years can be a QT prolonging thing. There are some people that think that perhaps deep breathing and things like that might modulate the QTC. However, I think at baseline, that QTC is a number that can fluctuate a little bit, but from a breathing perspective, moment to moment perspective, there may not be all that much change because of it. And what really matters long term is what that interval is, and that's one of the biggest indicators of what your risk may be if that number is very, very prolonged, and that's prolonged over sort of multiple ECGs. Question from Merrick. Merrick, hello. I have a few technical questions about QT measurement and interpretation that have been in my mind for a while. My local doctor couldn't really answer them, so I'd be very grateful for your opinion. Is it true that lead V3, the U wave, should be clearly separated from the T wave? And if not, it may suggest long QT syndrome. Is it correct that the Bazette formula tends to overcorrect, show longer QTC when the heart rate is above 80? I love the technical questions, Merrick. Thank you for the question. To kind of go back to square one, the QT interval, as you all probably know, is a measurement on an ECG. But the ECG has lots of different leads on it. Sometimes it's 12, sometimes it's 15 leads. And these leads are just different views of the electricity of the heart. Oftentimes, we try to measure in certain leads because the traditional way of thinking is that certain leads give you a better QT measurement. It's a little bit more accurate than in other leads. The most common leads I measure my QT interval in is lead 2 and V5. And so if those leads look really good and we have a nice clear T wave, a beginning to the QRS complex, those are the leads that I love to measure QT interval in. Those are the leads I default to. And they tend to be a little bit more accurate, at least in the traditional way of thinking. There are other leads that you could measure QT intervals in, like V3. But in my mind, if you have good measurements in those two leads, V2 and V5, I think you're probably in a good place to measure there. The U wave is a bit of a challenge. So sometimes U waves, which is basically a thing that comes at the end of the T wave, is kind of a hard thing to navigate. Oftentimes, I think we make diagnostic missteps when we don't know what to do with the U wave. And so the U wave typically is not part of the T wave. And so you want to try to ignore that as much as possible when you measure the QT interval. And there are certainly cases where that U wave was incorporated erroneously, incorrectly, and that individual was labeled as having a long QT. And so generally the U wave is sort of ignored. Now, sometimes the U wave smashes right into the T wave. Sometimes it's way after the T wave and kind of distinct. Sometimes it's blended between the two, kind of like a merger of the two. But it's always best to try to account for that and not get sucked into measuring at the end of a U wave. The Bezet's formula, which is just one of the ways that we correct for that QT interval, make that QT little c, you're exactly right, Merrick. Bezet's is sort of the traditional way that we do this. It's not the only way to measure and correct for heart rate, but Bezet's is most commonly used. It does kind of fall apart, the correction with very low heart rates or with very high heart rates. But with a heart rate of 80 beats per minute, I think you're right in that sweet spot. And in most situations, I would certainly default to a Bezet's correction in that heart rate range. But I love the technical questions. Next question is from Instagram, from Sarah. Is there any resources for us to get a travel AED? I don't have insurance, but need one badly. Aviv has a perfect one, but they are expensive. Indeed. So this is a really important point. A lot of families will say, hey, look, how can I ensure that my kids, my family are protected with something that's a life-saving therapy like an AED that we know is available to us because we bring it with us. And I think, a lot of families will say, hey, look, we feel very comfortable with the emergency action plan at the school, but there's a gray area when it gets to the away games, the away practices. And oftentimes a travel AED for those families is something that they consider. I completely agree. They can be expensive. You do not need a prescription to purchase an AED. So you can go to any number of online stores and buy AEDs, and most of them are pretty good. I would always go with a reputable brand, one that doesn't appear to be like maybe the cheapest thing on the market, but something that is a reputable brand that people feel comfortable with. But you can buy them. You can just go online and buy them. And these can travel with you. Now, they are expensive. They can be $1,000 or sometimes even more. And they're kind of a pain because you have to make sure that they're well maintained. So buying an AED once doesn't mean you don't have to make sure it keeps working down the road, and there can be costs associated with that. You're absolutely right. Insurance companies really oftentimes will, even when prescribed, will sort of reject the AED prescription and say, well, we're not going to cover this. And so many families are kind of stuck. There are some foundations which will help with resources for discounted AEDs. They don't provide them for free, but discounted AEDs, particularly when you've got the rejection letter from your insurance company. And Sarah, I love the question. What we can do is make sure that we get resources through the SADS folks to you all to explain these options. But there are some foundations that will help with this. But I completely agree. AEDs are important and they can be expensive, and oftentimes insurance companies are not exactly the best partners to help with costs. Can menopause? This is from Leanne Lashbrook. Good afternoon, Leanne. Can menopause interfere with long QT syndrome? I guess it's possible. So for biological females, for women, a circulating hormone, estrogen, that tends to go up during childbearing years, so it goes up during puberty, is present and cyclical during the childbearing years, and then goes down in menopause when those childbearing years are over. Estrogen it's a hormone that kind of blocks the potassium receptors that many of the drugs that prolong the QT interval also block. And so estrogen you can think of as sort of an endogenous. That means we make it sort of blocker of these potassium channels, and it can prolong the QT interval when it's present. And so sometimes women who are going through menopause where the estrogen levels may fall or may not be as high can see a mild shortening of the QT interval. And so you may see that when you go to see your SADS expert. The influence of estrogen on the QT interval can be quite small, though, and so it can vary. It can vary a little bit based on the day, and it's not a huge difference, but it does influence the QT interval. Uh, Really, where I tend to worry a lot is when estrogen as a blocker meets up with medications that can also prolong the QT interval, because those things together can lead to bigger changes with the QT interval and potentially a little bit more risk. And so, Leanne, to answer your question, menopause can, and it's tied to the amount of estrogen that's circulating in the blood. And sort of a follow-on question from Alona Tar, does from Facebook, does perimenopause cause can cause a risk of someone with long QT syndrome? So during those fluctuations in estrogen, which can accommodate perimenopause, there can be a little more fluctuation in the QT interval. But generally speaking, the effect of estrogen is not huge. And so if you're on your beta blocker of choice, if you're doing well, if you're relatively low risk, typically perimenopause and menopause are not things to necessarily worry tons about. But certainly, if you have additional, more specific questions, be sure to talk to your SADS expert. Question from Erica from Instagram. Hi from Germany. Gosh, it must be kind of late in Germany right now. Well, hi, Erica. Is there a connection between low blood sugar and long QT and CPVT? Well, for I would say for most causes of long QT and CPVT, there's probably not a very strong connection between things like hypoglycemia and like long QT and CPVT. There are some individuals with certain very specific kinds of mutations where potentially there could be some concern for alterations in the ability to secrete insulin and blood sugar, but those are fairly rare individuals with only very specific subtypes of long QT. But certainly for long QT and CPVT more broadly, typically no. Sometimes, particularly in kids, it's not so much the disease itself that can cause low blood sugar, but the medications we put people on. And so, for example, propranolol, which we use a lot for long QT and CPVT. Kids like it because it's easy to get solution-wise, so they don't have to swallow pills. That, as a potential medication, can cause lower blood sugar in some kids. And they can get kind of, they can feel like they have low blood sugar and get kind of crabby, like you might, after you've been working all day and haven't had a meal and you get kind of crabby from low blood sugar, they can kind of get that way too. And sometimes it can get a bit more serious if they don't get something to eat. And so, to me, when I think of low blood sugar and long QT and CPVT, I think of more maybe the effect of the beta blocker and less the actual disease state. Hope that answers your question, Erica. And I hope the weather is as beautiful in Germany as it is in North Carolina. We're getting a little bit of fall here, which is nice. We have Kathy from Facebook. How do physicians decide when to implant an ICD in Brugada syndrome patients, and when is it not necessary? When there is a confirmed diagnosis, it seems very scary to me when the decision is to implant an ICD, especially for children. And then there's a correction from us. Scary to not implant an ICD when there is confirmed Brugada syndrome. So Kathy, you're actually getting at a very important question, particularly for those individuals with Brugada syndrome. I think like anything else, it's an individualized question. And so Brugada syndrome to me is a challenging disease because it people vary a lot in the amount of risk. So, for example, you may have a Brugada syndrome SCN5A sodium channel mutation that has put other members in the family at risk of Brugada syndrome, and you at risk of Brugada syndrome because you have the variant, but you show no evidence of Brugada syndrome when you look by ECG. or when you look by a certain kind of lead placement, the Brugada lead placement that looks for where Brugada syndrome lives, which is a little bit high up in the chest. So they may move leads to look. And so if you have no evidence of it by those ECGs and you're asymptomatic, you've never had a scary faint that might be due to the heart, your risk is low. And so for those individuals, an ICD may not make a whole heck of a lot of sense, because we know that ICDs by themselves carry a little bit of risk. Um, the placement of an ICD is a minimally invasive procedure, but is a procedure nonetheless. ICDs can get infected, they can malfunction, they can have lead fractures. They require maintenance, right? You have to swap out the battery, you have to be monitored. And then in kids especially, they can fire at inopportune times and fire inappropriately when they shouldn't have. And so they're not without risk. And so in this scenario, if the risk of your Brugada syndrome variant is very, very low for you, your risk of Brugada syndrome might actually be lower than the risk of the ICD. Conversely, if you've had something very scary happen, like you've got Brugada syndrome and maybe there's been a life-threatening arrhythmia, maybe there was a cardiac arrest as the first sign that something was wrong, and then afterwards it became clear that you have Brugada syndrome, well then yes, that's the more extreme, higher risk version of it. And for those individuals, ICDs may make sense because the risk of Brugada syndrome in that individual is higher than the potential side effects of Brugada syndrome. I'll also say that ICDs that work in adults, sometimes they're under the skin, sometimes there's a device under the skin, but then the leads go into the heart. Those ICDs aren't always available for kids, and especially little ones. And so the smaller that you are, the less of an option those are, and the more actually invasive the ICDs become. And so for kids, oftentimes we'll drag our feet because that risk profile, the chance of the ICD could go wrong or the invasiveness of the ICD is higher than actually the risk. We may tolerate a little bit higher risk in kids because the ICDs have higher risk. And so to kind of sum up, you have a great point. I think it's one of the things where it's very individualized. There is a spectrum of risk. And so in general, if you're concerned about sort of a plan moving forward, questions to ask your SADS provider are questions like, well, so if you're saying I don't need an ICD, talk to me about what your view is of my risk. And that might be a very helpful conversation to hear kind of what that SADS expert is thinking. And then you can share what your idea of your risk is because their perspective of risk may differ somewhat from yours is. And so that might be the first question to ask to help have a conversation about this. Great question. A question from Leanne Lashbrook. I paid 900 pounds for mine and Philip's heart start. For the AED, they can be really quite expensive. They are expensive. Question from Dark Moon. Hello, doctor. I have long QT syndrome type 1. I take Nadolol 60 milligrams. I want to know which type of magnesium supplements is suitable for us. Well, thank you for the question. So I think this question of magnesium supplementation comes up from time to time. And the basic idea is that low magnesium in the blood can make things like long QT syndrome, both the QT and the arrhythmia risk, a little bit higher. And so sometimes people will say, well, look, magnesium supplements can help with that. And so are magnesium supplements something that we should do? And the answer is, perhaps. I think, if you're already taking a great medication like Nadolol or something like propranolol, magnesium supplements, I kind of think of are just that. They're sort of an add-on. I think in general, they probably shouldn't take the place of a beta blocker. Do they potentially offer a little bit of benefit? Potentially. But magnesium can do other things and can have some side effects, especially with kind of your GI tract and things. And so kind of the first question I ask is, well, if you're taking it and you have no side effects and you feel like it's helping, far be it from me to say you should stop. If you're having GI side effects and you're well controlled on your beta blocker, you may not need magnesium supplementation. So it's kind of a case by case basis, and whether they agree with you or whether they don't. Kind of goes back to that risk and benefit calculation that we make. If you're having terrible GI side effects from it and you're not getting much benefit, then it might not make a lot of sense. If you have no side effects from it and you're maybe getting a little bit of benefit, it might make sense. I think beta blockers are probably the frontline therapy, though, when we think about best ways to treat long QT syndrome type 1. Melissa from Instagram. Good day. Does long QT syndrome cause gross motor delays in walking, or can the beta blocker or propranolol cause delays? This is Melissa from South Africa. Well, Melissa, thanks for tuning in. I think so far you get the award for the question from the furthest distance, although maybe we'll see if there's a question from further away. I love the question. So in general, long QT syndrome does not impact a child's development. There are some exceptions where long QT syndrome can overlap with some very specific syndromes, but I would say in general, gross motor delay is not something that is oftentimes associated with long QT syndrome broadly. And the question of beta blockers is a good one. Oftentimes, parents are asking, well, look, if you're putting my child on a beta blocker, what are the possible side effects, right? Does that in any way impair my child's ability to grow and to thrive and to develop normally? And the answer is no. There is no evidence that propranolol or beta blockers in infants alters their normal development in any way. And in fact, just the opposite. If your SADS provider is talking to you a bit about starting a medication, and after a conversation you agree that there's risk there, that medication is helping to lower, oftentimes it is a reasonable thing to consider propranolol even in little tiny babies. And so you shouldn't worry about things like altering development. The biggest worry, in fact, is actually that low blood sugar. And so that we talked about previously, not necessarily altering development. Carrie from Instagram, can you get a pocket AED in North America yet? I don't actually know the answer to that question. I would presume that you can somewhere, but I actually don't know. So maybe what we could do is get back to you about that, Carrie. I would say, just from personal perspective, the one thing I would just want to make sure of is that the AED that you're getting, whether it's a pocket AED, a travel AED, a cheap one, an expensive one, is one that will work well. Because in situations where you need an AED, you don't want to be worried about, is it going to do the job it needs? And so, gosh, I certainly love the idea of a pocket AED. And as long as it works well, I'd love to be able to see that as an option for families that would like one. It would make things a little bit easier, because you're right, some of those AEDs can get pretty big. From Instagram, is it Bushra? I hope I pronounced your name correctly, Bushra. What about dentists? I'm a long QT1 on Nadolol 60 milligrams for 30 years, symptomatic, and I'm really afraid of going to the dentist. What are your recommendations? Well, Bushra, I don't think you're alone, certainly, in not loving to go to the dentist. This question comes up frequently. I think from my perspective, when you have, speaking generally about long QT or any other SADS conditions, the goal of your SADS expert in treating your disease is so that you can live a happy and full life. Going to the dentist is just one of those, like, people may not love it, but it's super important. We know that dental health reflects on our general health. A healthy mouth is a healthy heart, for example. If you never go see a dentist and there can be cavities and infections in the mouth, we know that can actually cause trouble with the body overall, and can cause trouble with the heart. And so if you need to go to the dentist, I would say go for it. Generally speaking, our advice is to stay on your medications. Now, if you're symptomatic, then I would probably treat that differently. So the first question from a SADS perspective would be, what are you symptomatic from? So if it's, gosh, like I feel palpitations, I feel really anxious, I feel nervous about going to the dentist, that's one thing. If you say, no, you know what, I was running and I had a faint, that's something entirely. So I would talk to your SADS expert about symptoms, because it may be a sign that your long QT1 might need a tune-up, might need a little bit more control. And then in that setting, if everybody says, oh, look, your long QT is under control, you're doing well on 60 milligrams of Nadolol for 30 years, and you should go to the dentist, generally we say, go to the dentist. Take your medications the day of. Sometimes people who are really afraid of going to the dentist can have a little bit of light sedation, which you can talk to your dentist about. Generally, we say take your medicines the day of, and there's no trouble with you getting a little bit of light sedation. We generally say, avoid QT prolonging medications, and to have your heart rate and your pulse ox in your blood monitored, which is usually standard when you're getting a little bit of light sedation for like a teeth cleaning or some dental work. And then oftentimes the dentist will ask, well, if you have a heart condition, do you need additional antibiotics after maybe like a tooth extraction or some cleaning? And the answer is no. You don't have a structural abnormality of the heart, but for long QT symptoms type 1, you shouldn't need those extra antibiotics. And so have a conversation with your SADS expert if you're having symptoms about what that means for you and your risk, and then have a conversation about seeing a dentist. It's an important thing. I love all these questions. You all are wonderful. Keep them coming. Our next question is Benet Sisma. What is the standard treatment for CPVT when you can't tolerate beta blockers due to low blood pressure? Wonderful question. So sometimes, for individual CPVT, we oftentimes start with beta blockers, and we try to go up on the dose because we know that those beta blockers are really important for preventing the arrhythmias, which can become life-threatening in CPVT. And oftentimes we push the dose high because the more medication we can get in, the more protection you get. Now, sometimes, as you indicate, Binet, like sometimes your blood pressure goes down too much or you feel too crummy with the beta blocker dose as it is. Sometimes, people can't get out of bed. Sometimes they feel really woozy. Sometimes they even have a faint, not because of their heart rhythm, but because of low blood pressure, and the heart's ability to elevate the blood pressure is a little bit dampened by the beta blocker. And so in that scenario, oftentimes we'll say, can we come back on the dose? Is there a dose that's a little bit lower that still provides the protection to your heart without having the symptoms? Now, if the answer to that is no, and sometimes it's not, there are second-line therapies for CPVT, meaning medications that we use after the initial medication, beta blockers being the initial medication. And so those second-line therapies oftentimes are other types of antiarrhythmics. One that's often used in the situation is flecainide. And so here at Duke, if you're not tolerating beta blockers, or you're tolerating it, but the beta blockers aren't doing their job at the max dose that we would use, then sometimes we would add on that second-line therapy of flecainide. We have some patients who still, even after that, they still have trouble. And then, in some of those situations, there are other steps that can be taken. For example, in some situations where beta blockers are not tolerated, flecainide is working okay, but there's still lots of arrhythmias. Or, sometimes flecainide isn't well tolerated. That's when we would think about other non-medicine interventions. And that's where sometimes a conversation about a cardiac denervation surgery might come into play. But again, it's one of these individualized approaches that you should have with your SADS expert. But certainly the last thing we would want is for you to say, stop taking the beta blocker because you're feeling crummy with the beta blocker, and then have the risk of the CPVT. So your SADS expert will work with you to come up with what those other options are for you. Andrea from Instagram. My son recently had sudden cardiac arrest. He was found to have an RYR2 mutation, but only partial. He's scheduled for a SICD surgery. Any information on the partial mutation since he was not diagnosed with CPVT? Well, it depends a little bit on the nature of the mutation and kind of what you're thinking of in terms of being a partial mutation. So sometimes partial mutations might mean that there's a little bit of uncertainty, meaning that the gene testing company said, well, we found something in RYR2, but we're going to call it a variant of uncertain significance, meaning we're not going to have enough confidence to say this is the cause of your son's cardiac arrest. And that can be a bit of a challenge. Oftentimes, your SADS expert might work with you to clarify that. Depending on the type of cardiac arrest and the situation behind it, that variant of uncertain significance in RYR2 might actually not be uncertain after you and your SADS expert look at it. Now, sometimes RYR2 mutations, if you mean by partial, mean that only one copy of your two copies of RYR2 are mutated, meaning it's heterozygous, meaning you have a good copy and a mutated copy. That's actually fairly common. And so most mutations in RYR2 are heterozygous, meaning only one of your copies of RYR2 is mutated. And then there's lots of different other permutations depending on sort of what that mutation actually is. And so, discussing the particulars of that mutation with your SADS expert, I think, is a great place to start. Now, it sounds like he's scheduled for an ICD surgery. And speaking broadly, I think oftentimes if there is a cardiac arrest and there is concern about something like CPVT, ICDs are something that are brought up, but it really depends on kind of the individual. It really depends on medications that are being tried. It really depends on the outcome of that gene test. So I will say that it's really important in these scenarios like this to have a conversation about, well, what do you think as a SADS expert, asking them, what do you think about this variant as being the cause? And sudden cardiac arrest is sort of what brought you in, but that by itself isn't a diagnosis, right? Do they have CPVT, for example, catecholaminergic polymorphic ventricular tachycardia? Do they have something else? So I might seek clarity in situations like this as to what is the diagnosis that might have caused the sudden cardiac arrest. How does this gene test, partial or not, play into that evaluation? And then from there, work forward and say, well, what's the rationale for the ICD? What are the risks of an ICD? What are the benefits of an ICD? And so I might start there, get a little more information, figure out what the underlying diagnosis may be, and ask those questions. You're on the right track. And we're almost at the top of the hour, so maybe we'll take one more question. Sanja Grods asks, I hope I pronounced your name correctly, Sanja. Can you advise on correct propranolol dosing? I'm a 39-year-old woman with long QT syndrome type 1 with an ICD, history of sudden cardiac arrest. I'm only on 80 milligrams, and this seems low based on my recent research. So, speaking a bit more broadly about individuals and beta blockade. So a few things just to be aware of for anybody who's taking propranolol versus something like nadolol. The dosing matters, how much you're taking, and the frequency that you're taking it also matters. So, for example, nadolol can be considered a once daily medication, meaning you could take that medication once a day and it covers you for 24 hours. There are some individuals that will break the dosing up. There's some individuals take it at certain times of the day, but it's kind of a 24-hour medication. Propranolol really is not. And so it depends on how frequently you're taking it. And if you're taking it enough where when the propranolol you take it goes out of your bloodstream after a few hours, you've got that next dose ready to take the next dose so that you can make sure that you're covered for the full 24-hour period. So the first thing is making sure you're taking it with the right frequency. And it depends a little bit whether you're taking an extended release versus a non-extended release propranolol. And then there are all kinds of considerations about like how high risk are you? And so if you're long QT syndrome type 1, you've got a mutation, but you've never had a QT interval that's prolonged in your whole life, you've never had a symptom, uh, your risk and your need to be on a very high dose beta blocker might be quite different than somebody who's got a very prolonged QT interval and who's at much higher risk. And so I would say that your propranolol is one of the medications we'd like to use. If you have questions about your specific dosing, the frequency, and your risk, I would discuss those concerns with your SADS expert. Well, unfortunately, everybody, we are at the top of the hour. It is now 3 o'clock North Carolina time. I just want to thank all of you for your wonderful, your insightful questions, your engagement. Thank you to SADS for allowing me to pinch hit for the excellent Mike Ackerman. And definitely check out SADS for more things to reach out with this sudden cardiac arrest community, especially knowing that October is Sudden Cardiac Arrest Awareness Month. So thank you all. I hope you all have a wonderful day and enjoy your weekend. Bye for now.